I've started the recording now, Richard, so that's
Okay,
great.
brilliant. Thank you.
Perfect. Thank you for being so responsive. I'll crack on now, conscious of time. Thanks so much for having me along here today. I'm Katy Styles, Clinical Lead for Realistic Medicine in Grampian. My background's in occupational therapy, and I've worked in a range of roles, including community-based case management. So I very much consider myself a generalist clinically, and I've also got experience in education, and hopefully some of that will show as I take you through this project. So partnering to improve migraine management. And I've called this realistic medicine design, and hopefully by the end that will make sense to you. So I'm hoping to take you through a little bit of context around realistic medicine, what this project was, how we approached it, what it's achieved, and then in terms of involving people, very much quite subjective, but my top tips about what we've done and what has worked well in this project. So realistic medicine was introduced by the Chief Medical Officer almost 10 years ago now in 2016, and it identified that the traditional, it talks about the doctor knows best, but I would widen that out to the clinician knows best approach as really no longer being fit for purpose. And in that report, it set us all a challenge about how we design and develop health and care services that bring out the best of expertise, not only of professionals, but of people and their expertise in themselves in their own lives. And I think that's really key in terms of what I'm talking about today. Around about that time as well, there were some fairly large-scale landmark international research, and it found that up to 1/5 of our healthcare resources are wasted. And it really boggles my mind every time I read this. It never fails to surprise me. So recognising these challenges, realistic medicine proposed 6 pillars as a response to these challenges. So shared decision making, building a personalised approach to care, reducing harm and waste, reducing unwarranted variation, managing risk better, and becoming improvers and innovators. And I share this because this is really the context from which this project was delivered in Grampian as part of the Realistic Medicine programme, and also because it's my life's work to raise awareness of what realistic medicine really is with tangible examples. So I'm going to move on to the project. So a little bit of background. First of all, why migraine? It's estimated, and it's probably an underestimate, that 1 in 7 people live with migraine. So the bid for this project was co-designed by migraine specialists. So that included the Migraine Trust, a neurologist who specialised in migraine, a GP with special interest in headache, and a pharmacist. The bid was successful, and as Richard said, it was funded by the Neurological Care and Support Framework. That was initially for 12 months of funding, which commenced in January 2023, and we had some core deliverables, and it was taking a project management approach to upskill 50 community pharmacists on migraine management, production of materials for 132 pharmacies, which is how many community pharmacies were in Grampian at that time, and that we would deliver a Manage Your Migraine public information webinar. And just as a note, that the main bulk really of the funding was the project management resource. We had a full-time project manager around this. As Richard has said, we had a further 12 months of funding, so that was from January 2024 until January this year, and that was to support the rollout to at least 3 other health boards, and there's already been a spoiler that it was 6 in the end, and then further work to embed the project in Grampian with a real focus on sustainability. Because of the time available today, I'm going to largely focus on the Grampian-centric work, in particular year 1, because I think that best helps you understand really the story from the outset, but there is some of what I will share from year 2 as well. So what did we do? The model here is based on the theory of design thinking, which is about putting the user at the heart of any design. So starting from a place of empathy, so really understanding the needs of the user. It sounds like someone might not be on mute, and I'm just wondering if you can pop yourselves on mute.
It's very interesting if you've got migraines, it turns out.
Thank you. So in terms of starting from that place of empathy, this is, I guess, what I'm describing from the outset there about how do we actually put realistic medicine into practice in terms of project and service redesign. So really thinking about shared decision making as a way of working. So setting aside our assumptions about what training should look like, what a public awareness campaign should look like, and actually gaining insight into the users and their needs and their thoughts and opinions around this. And we quickly identified really there were two main groups of users thinking about that design thinking model. So people living with migraine, but also pharmacists. We needed pharmacists to engage with the project for it to be successful, as well as we needed people living with migraine to engage with it. So how did we do that? We started off, so we did this both for people living with migraine and for pharmacists. We started off with a focus group, and in terms of people living with migraine, we promoted that through our staff bulletin, recognising that if 1 in 7 people live with migraine, that's going to be a lot of our staff in NHS Grampian, and that was also a fairly straightforward way to pull together a focus group quite quickly. We had 16 people join that group, and we followed it up with a wider survey. So we were asking questions around what mattered to the people. Had they accessed pharmacy support? If they hadn't, what would enable it? And how should we be spreading the word around the project and around migraine awareness in general? And that served multiple purposes. It absolutely informed the project, and hopefully you'll see that as I continue. There was also real two-way learning around, I suppose, that bit of assumption testing that I've mentioned early on. And some of the things were so straightforward, but we assumed that people would know. For example, people had a real concern about accessing support in pharmacy if they had to stand on the counter and do it, and we were able to share that all pharmacies have a consultation room. So some really straightforward things like that, but that we wouldn't have known had we not asked those questions. But there was also a further benefit, which was the sort of support network that the people in the room felt being brought together and being able to share experience as well. And that's something that I'll go on to explain a little bit later about what we did more of in phase 2 of the project. So we did similar with pharmacists, and we did very much a similar approach. So we started off with a focus group of pharmacists, and our migraine experts led that focus group, and they started off, so thinking about adult learning theory, that the hierarchy of competence, that what we didn't want to assume that people knew what they didn't know. So they delivered a short baseline training session to make sure that we sort of established that level playing field, if you like, of those who attended the focus group. So we weren't making assumptions of what they might not or already know, and created a safe space to really find out what we needed to then shape up the training. And some of the things that we heard were, again, really fundamental to then how we shaped up the project. So loud and clear, it was just pharmacists that came along to that initial focus group, and we heard loud and clear that any training shouldn't just be for pharmacists, recognising that if you go into a community pharmacy, it won't often be a pharmacist who will meet you. It might be a counter assistant, it might be a pharmacy technician. So there was a real ask for us to think about how we could involve the whole pharmacy team and make training available to the whole pharmacy team. And one of the really interesting bits as well that we heard was that the people that came to that focus group, which we did in person, they said, oh, training should definitely be done face to face. But the wider survey showed that, in fact, the majority was that people wanted to do it virtually. So there's a bit there about triangulation of approach, a mixed methods approach really in triangulating the findings from those focus groups. So as I've indicated already, what we found was then we had those core deliverables, but it was used to then shape what they would look like. So to develop the project outputs, the training content, the public awareness campaign, the resources that we developed, and the public information webinar as well. And really crucially, it was also used to inform our communication plan. So we checked with people what was the which social media platforms to use. Facebook came through loud and strong. And we really noticed that a lot of community groups, if things go through NHS Grampian, I guess a trusted partner, lots of local community groups then will repost things. And that seemed to be a really, really effective engagement strategy. And just for clarity, this was all developed concurrent with the National Headache Pathway. So that bit around unwarranted variation that I spoke about in terms of realistic medicine, as well as listening to those views, we were making sure it was concurrent with the National Headache Pathway, which was a work in progress at the same time as this, but has since been published. So what has this project helped us to achieve? So some of the numbers, some of the data that we do have in terms of pharmacy teams, who did we reach? So in that year 1, we had 206 self-directed learners. So an e-learning module was developed, and we had 206 people access that module. We did 4 live workshops. One of them was face-to-face, 3 were virtual, and we had 86 86 attendees came to those workshops. And what we know from workforce data around that time, that we'd reached approximately 30% of community pharmacists in Grampian and around 25% of prescribing pharmacists at that time, but we do know that that number is shifting all the time. We did pre and post training evaluation, and that showed an overall shift in confidence and knowledge following the training. People living with migraine, some of what we achieved in terms of some quantitative data, the Manage Your Migraine event, so that public information webinar, which was part of those original 3 objectives from the original bid, this really blew us away, and I'm going to share a bit of a secret here. In the original bid, it was indicated that we would reach 200 people with the webinar, and really early on in the project, we reduced that to 50, and that was based on the Migraine Trust's experience of running webinars regularly that are open to all, so they're available nationally. However, in the end, we had over 900 sign-ups to that webinar. Over 450 people attended on the night, and within 24 hours, a further 416 people had watched the video on YouTube. And I guess I can't evidence this necessarily, but I have no doubt that this is because of the communication strategy and how we engaged with people living with migraine throughout the project. And some of the other data about that event, so we knew that 81% of attendees were living with migraine themselves, a further 8% had friends or family living with migraine, and 91% of those who completed the evaluation agreed that it had improved their understanding of migraine, and 76% said that it helped them with concerns and anxieties. So just moving on, any good researcher is always transparent about limitations, and the main challenge really about this project, and perhaps unsurprisingly, has been the feasibility of obtaining robust service level data about the impact of this work. So what I mean by that is, have we had any impact on general practice, people going to pharmacy rather than going to general practice, or even into secondary care, and that hasn't been possible to obtain. However, what we have done is we've gathered stories from pharmacists, from people living with migraine, from wider healthcare professionals. So what we do know is that the impact has been widespread. I've tried to pull this together in a little bit of a visual here. I've also included several stories that I'm not going to go through because it would take too long and the time's limited today. But I've asked that the slides be shared because I would really encourage you to read those stories because they are quite powerful in terms of the reach that we've had with individuals across the system. But just to summarise what we have heard is we've heard individually people have a better understanding of their condition, people who have recognised misdiagnosis. There's a really, really powerful story about misdiagnosis of chronic sinusitis and years of treatment, unsuccessful treatment before that. People feeling better able to prepare for appointments and feeling more confident taking and combining medication. So overall, really improved self-management. Wider impact, so we've had loved ones share stories about having better understanding and being better able to support their loved one and less concern about other causes of headaches. So there's one story about someone had concern about it being a brain tumour and felt really reassured accessing the resources developed. Wider healthcare, we've got stories of pharmacists feeling much more confident to recognise and treat. Improved signposting from GPs, we've heard that from a GP, more appropriate consultations and fewer misdiagnoses. And then in terms of wider impact, we've done work locally with NHS Grampian as an employer, and we're working towards signing the Migraine Trust Pledge as a more aware and supportive employer for people living with migraine. We've reached a wide, those numbers I've just shared about the webinar, so that overall public awareness, we anticipate reduced impact of sickness absence. And again, there's another story in there that really shines through, and hopefully some wider community understanding and recognition of migraine as well. So I'm just going to skip through the stories that I've mentioned there. And like I say, I would really encourage you to go back and read them. And I just wanted to focus a little bit on a particular bit that we did in year 2. So in year 1, at that very first focus group, we really heard about the value of the peer support opportunity. So in year 2, we incorporated peer support sessions, which were facilitated by Grampian Hospital Arts Trust, and that was 2 creative writing and 2 art room sessions. And we had 21 participants came to those, and an overall rating of that session as 5 out of 5. I've included some of the feedback here about participants felt it was useful to offload some of their stresses. They really benefited from that, meeting with others and listening to how other people live with migraine, and it felt like a safe environment where they could share that. So I'm hoping that I've described what we've done here and how we've used the pillars of realistic medicine intrinsically to the design of the project. And very lastly, I just wanted to run through, I guess, very quickly my top tips about how we've involved people. I think the value of project and programme management in that we're change agents, and also we were able to bring the capacity to make these things happen. I think starting somewhere is a really good thing to do, and it's about progress and not perfection. And I think that we learned a lot from our approach in terms of starting with staff, and we really recognise now the value of that, and working in order to work in partnership, recognising the continuum, the clinician-patient continuum. We had people that attended the webinar living with migraine who were also clinicians, and I think that blurring of lines has actually been really helpful in terms of achieving that partnership approach. A stepped approach can work well, so starting small helps to build confidence in everyone around this work in how we do involve people with lived experience. I've mentioned triangulation, so that mixed methods bit, and not I guess not going with the first thing that you've heard without maybe sense checking that, asking you questions, being transparent, but also using the feedback that you get, and hopefully you can see we've done that throughout. And also that engagement is keeping that thread of communication going. I'm just going to stop there, and apologies, I think I've gone a couple of minutes over.
Sorry, folks, my phone just decided to ring as soon as you finished there, Katie. Thank you. That was brilliant. And probably doesn't do it justice in the time available. So, if anybody wants to read more about that, there is also, as well as Katie's slides, which we'll send round, there is also a full report which the Migraine Trust did partnership with NHS Grampian. That's available on our there's a link available to that on Scottish Government's website. So we will we'll go straight on to Louise, and we'll open it up for a Q&A discussion after this second presentation. Thank you, Louise.
Right. Well, I think what I'm going to talk about really links in with what Katie has just spoken there about taking a service design approach and so on. So I work with the Care Inspectorate, and we both inspect services and help them improve. And my role is supporting care services across Scotland to get even better at what they do. So I'm going to give you a glimpse of how a new network was established in Ayrshire and Arran, and how we brought people living with neurological conditions together with health and care staff who support them in their own homes. And I'll show you what we got to in terms of what the network thought was most important to work on going forward. So you can see that Jenny and I are the first 2 people there. Jenny Preston is on the call, and I'm sure many of you know her. And we invited 2 others with complementary skills to join us on the steering group, Hannah and Helen. And it was extremely helpful to have people not connected to the sector involved with this work, because it certainly gives you a different perspective as well. So this was our task, and you can see from this that we're very much focused on the process about learning and working together, as well as the outcome about building a network. And we needed where to start. We needed to reflect the principles that everyone here is committed to about co-producing something in a person-centered way. But how do we bring the proposal to life? The proposal we'd originally put in. We wanted to bring people experiencing care into the heart of a new network and decide what the new network would look like. So we spent a lot of time thinking about how you have the theory of co-production and service design and so on and so forth. How do you put that into practice? To build a space for conversation and to bring people experiencing care, care professionals and health professionals together as equals. We wanted it to be more about conversation and knowledge exchange, not about, the professionals imparting knowledge in that. So this time that we gave to thinking about, well, how are we going to do this really paid dividends later. I'll take you through that. So here's what we ended up doing. There's 6 stages there. So it looks very nice and neat here, but these were developed and amended as we went along. And we really did start with a blank sheet. So I'm going to focus on stages 1, 4, and 6. That's the preparation, the developing conversations, and how we, ordered the priorities that we eventually got to. So we'll have a look at those. So stage 1 is about background work and thinking about this, because to build a space for conversation where deep listening could take place with shared understanding. And we thought about how we'd achieve what's there on the slide, but taking a cohesive approach so that all of our communication about what the project involved, how the project space was set up, our interactions with participants, how we facilitated and so on, needed to connect about welcoming conversation and hearing everybody's voice. And I think if I press this, yeah, you'll see an example of an invitation here. Sorry, it's in blue for some reason, but it's asking, do you have a story to share? It mentions an informal event. It gives some options about how to get involved, because again, folk living with long-term conditions, with fluctuating health, it's very, very difficult to just commit to things. So you'll see as well that we're using some graphics here, and we're going to see a lot more of those, because Helen used graphics and graphic facilitation to make sure that everybody could contribute each time we met. So when we did invite people together, we divided people into 3 groups where there was a mixture of folk experiencing care and living with neurological conditions, and also health staff and care staff at each table. And like Katie was saying, actually, some of the folk who were care staff or health staff also had experience with either themselves or with family members of people living with neurological conditions, which that added to the richness of the conversations. And so small table conversations took place about each topic, and then Helen pulled this together for us at the top of the room and asked us for more details and confirmed meaning, which really aided in the clarity and also the consensus of the room. So let's have a look and see what some of these looked like. And also for our first one, we asked people, we didn't jump straight in and say, what do you think we should be working on as a network for neurological conditions in Ayrshire Arran. We started about our common humanity, and we asked people at tables about what makes our heart sing. And this ensured that nobody was given greater authority or credence than anybody else. And it really did help promote equity and a focus on us on people with the same interests and passion. And I'll just pull up some of them here. So, whether it was getting outside in the fresh air or spending time with family, it was a great equalizer to start. And, it's not about, say, us, the professionals, and them, the people with the condition. It was about us as human beings, and what we're all trying to live our best lives in the way that matters to us. And that graphic facilitation helped to equalize the power and make sure that everybody's input was valued and recorded with equal weight. So having done that, this is our first session. We also focused on the positives, what's working well in this area of people living at home with neurological conditions and the care they get. And also, naturally enough, heading on to what more could be done. And even the terminology there about what more can be done, it's not what's wrong. It's about taking a strength-based approach and really looking to the future. And you might think like, well, now we have, well, what more can be done? These are the things that we should just hone in on. And these are the things the network should work on. But what we did next was take some time to think about, well, from what worked well and what more could be done. We established from those first conversations these 4 themes. And sorry, the little blue things are, comments from participants as we went along. You'll see some of those. And we wanted to keep things flexible and open for as long as we could before tying ideas down. So time was given to consider each of these 4. So, for example, one there is about being person-centred. So we want, and we know from staff that and from folk experiencing care that being person-centred is an issue. But what does it mean to be person-centred? So we spent more time deepening those conversations. And here's the second bit I want to talk about, stage 4, about deepening these conversations and building in space for people's stories to be heard, for different views to be shared. And you can see a snap photo there from one of the events. And from that, we really honed in, well, what does it mean to be person-centred? What does it mean to have continuity provision, which was another one? And what is it about communication? What would be even better with the communication? Now, from these 4 themes, there's lots of numbers in this actually. So, we went from our first event into the 4 themes, and from those, with these deeper conversations, that led to over 90 issues being gathered. And from this, we did a thematic analysis on those 90 issues, which was fantastic. Hannah did a great piece of work there, and it produced 18 different priorities. And here's one of them. And that's a photograph of, it's an A4 sheet, a laminated A4 sheet, so it's a bit shiny there. And on the front is one of the priorities, number 17 as it happens, working on ways that it's important for the network to work on ways for people with neurological conditions receiving care at home to have more control over their care by collaborating with health and care professionals. And on the back of it, you can see, well, where did that come from? And there's 1, 2, 3, there's 5 different issues that had bubbled up over the conversations in the previous previous events. So from that, we had the 18, and Helen put these on laminated A4 sheets, which we were able to bring along to our final event, this is stage 6, where we wanted to prioritizing, putting them in order. And there's 2 different groups there working away on them. And you can see the group on the left have them all lined up, 1, 2, 3, 4, 5, 6, etc. And that was a start for each of the small groups that were working away. And from this, looking to see, well, which are the most important? Can we move them up? Can we move them down? That was really, really helpful to have the physical objects to move around. And, people eventually were standing up, and you can see the group on the right. They've divided them into 3, the very most important ones, and there were lots of conversations about, moving them up, moving them down. How do we decide what's most important to work on? And once again, people getting the opportunity to put their ideas forward and be listened to and considered, and no one voice being more important than the other. So from this, we had the 3 groups with their prioritization order, and we put that into a spreadsheet and with weightings, etc., and came up with further participants, which were the top ones. And they're not all there, but you can see, which ones came up at the end from all of these. So hopefully this has given you a flavour of how we moved from the principles of involving people to concrete outcomes, and very much using a person-centred approach and using ways that were very holistic and ethical, and building on relationships and being strength-based or asset-based. So the top 4 that came up there, there was some overlap between the priority areas, and all 18 were important, but the top 4 that came out were the ones that people felt could effectively be targeted for development by the network going forward. These are the 4 to step forward with. And one of the things, like Katy, we were interested in the process as well as the outcome, and some of the questions that we asked around evaluating the whole thing, we asked people about, were the priorities chosen? Are they the ones that are most important to work on? Because that's what we were hoping to get to. And you can see other things about, personal engagement and people being valued and so on. So everybody who took part strongly agreed, most of them strongly agreed or agreed with all of these statements at the end. And as Katy was saying as well, with the Kirkpatrick, we have to get on and actually put them into practice now with the network, which is starting up in July, beginning of July. And one participant told us that taking part had a profound effect, and that she's going to continue with a new continue with us without an advocate, and that wasn't possible before taking part in the project. And she said that it's given her the confidence to advocate on her own behalf and to use this confidence in other parts of her life. And I think it's really important to focus in on this because, well, what did we do differently? Well, on the one hand, you should think, well, nothing much, because actually treating everybody with curiosity about their thoughts and their ideas, that should be a baseline for any of the work that we're involved in. But it just shows the importance of, if you take time and consider how you're going to give everyone a voice, and not just the people who are confident to speak up, that, well, for one thing, you have a much better result and better outcome because you've managed to include a diverse range of voices, but also that this can have a really positive effect outside of the room for other people who are involved. So that's a whistle-stop tour through it, and thanks very much from myself and Jenny and the others. And I think we'll have a chance to take questions in a wee while. Thank you.
Thanks, Louise. And again, yes, as you say, it's a whistle-stop tour, so possibly doesn't do it full justice. But I'm just going to open it out to for questions on both presentations. So if anybody would like to ask Katy or Louise something, then please put your hand up. Okay. Suppose I'll ask something then. As chair's prerogative. I suppose in terms of, obviously that's quite for both projects quite an involved process, and how, Louise, in terms of embedding some of those 4 priorities, what would you see as kind of being the main things that you'd want to focus on in terms of service design or sort of progressing some of these the issues that people wanted to improve?
Well, hopefully Jenny will be able to jump in here as well, but the intention is to continue using the same approaches that we have started with establishing this network in the first place. So one thing I'd say, so again, in terms of, we've got a plan of action around what to do, but we're with the network, for the network to decide on the next steps and how best to take each of these forward.
Thanks, Louise.
Do you want me to jump in? I think there's lots that has come out of this, and as everybody knows, this is a very 15-minute sort of presentation. But some key things that have come out really are around training and development. So how do we support, particularly around person-centeredness? And I think that's a topic that we all know about. Katy, I'm really interested in some of what you were describing, because there felt some real alignment between both the projects. And I think, we know that we need to be perfect person-centered as clinicians in particular, but actually, how do you do that? and what does that look like and how does that feel? So I think we had some really good examples there within our work around what that actually feels and looks like. So there's scope to do some sort of training and development around that. There's also some aspects around service design in terms of systems and processes that we access and that we use and how we improve on that. So there's quite simple things that we can do very quickly just in terms of enhancing that experience for people. But I think the key thing for me that came out of it was, and this project really started from the concept that the way that care is delivered, and this is not a criticism, but the way that care is delivered is fairly set and structured. And there was a sense that people living with a neurological condition might have different needs. And I think we saw that in abundance. And, we had a range of ages of people being involved, and their needs were very different. So we had the whole sort of continuum from people who were at a fairly advanced stage of living with a neurological condition, who had fairly extensive personal care needs, through to a young person living with a neurological condition who had left the family home to go and study in university. So what did that experience feel like? So that care program needed to look very different to somebody in a different sort of circumstances. So I think it really opened our eyes in terms of what are the needs and what does that look like. So there's definitely more work to be done, but I think the key things for us were around systems and processes and around the uniqueness of every individual, which we all know, and of course it's obvious when you see it, but really thinking about that and how that impacts on the way that we organise, request and deliver care. So yeah, lots of work to be done in relation to this piece of work. So hopefully that helps a little bit as well. Thank you.
Yeah, definitely. Thank you, Jenny and Louise. Are there any other questions? So, Lynn, good to hear from you.
Thank you everyone for your presentations, really interesting. And I suppose I'm just really thoughtful and reflecting here that what I've heard and what some of the work we're doing locally around strength-based approach and really moving to that different model of moving away from a medical fix-it model, which I think in all our training and our professional careers, that's, we absolutely were led with that model, weren't we? That we were there to fix and there to, solve things. And while actually what we're looking to do is change and really focus on that strength-based approach. And I'm just thoughtful how we move this forward. So we've done some training locally, but trying to release staff, and then you need to get a tipping point of the amount of staff that have done the training to start to really be able to role model that and change the way that we're approaching consultations or information that's shared with patients. And I'm just thoughtful on Katy, Jenny or Louise, any thoughts on how do we move forward with some of the training needs for neurological conditions in a way that's not everyone having to do it themselves? Is there something nationally we can do that makes a toolkit of training, but how do we release staff given the pressures? So just really thoughtful if anyone has some reflections on that. Thanks.
I'm happy to pick up on that because that's exactly where we're at. So we had, the funding for a year. The idea was to sort of develop a prototype for a network, and the network will continue. And that's not with funding. That's just going to be subsumed within sort of local capacity, if you like. But one of the things that we are doing is having some conversations with one of the universities at the moment in relation to, is there scope to potentially turn this into a knowledge transfer partnership, so that there would be further generation of income through the KTP, but we also would still have to find some of that sort of funding, because that's a joint funding arrangement. But that's maybe a model that could potentially help to go and do some of that work, to do a lot of the groundwork and to do a lot of the sort of preparatory work in terms of developing training needs. And some of the work that we're talking about isn't just about clinical stuff, but it's about, you know, mathematicians, it's about statisticians, it's about, you know, business, all sorts of different things that, you know, disciplines that come into that. That's way out with the reach of us as clinicians, because we have other work to do as well. So there's something about how far can we reach out with this. But I think you're right, Linda, absolutely. Is there a national model that we could contribute to and engage with other people to help develop something? I mean, the optimum for me would be that we have this sort of programme led by the Care Inspectorate that is delivered to everybody involved in delivering care at home. But, you know, we're a long way off that. But, you know, that would be the optimum. But it's, you know, I think what we've learned is not necessarily what we expected in a really positive way, because I think it's so much more than what we expected. And it's that thing about you have a hunch and you think there's maybe something here, but actually, you know, the richness of what we've discovered already has been really, really powerful. So we absolutely don't want to let this go, as you can tell. We absolutely don't want to let this go. But you're right. Is it us that takes that next stage forward? And there will be some things that we can do locally within the network, but there's also a much bigger picture here as well. So it's looking at where else that support might come from. So I don't know if that helps. If you've got a pot of money and you want to join us, then please do.
Thanks, Jenny. I've still to read the service renewal framework that came out. So I don't know if there's anything I mean, there is stuff around there in staff training and development. So it might be that there's something within that we could draw on. Okay, are there, just to sort of mention that I know there's a few people did join late. We have recorded this session, so we will distribute the recording afterwards for people that want to see the presentations that have missed them. So are there any other questions anyone wants to pick up on? No? Okay. I'm going to give hand over to Alice Struthers, who is from the Neurological Alliance of Scotland, and she's going to talk a little bit about a leaflet for professionals who are working with people with neurological conditions. So over to you, Alice.
Thank you, Richard. Thank you for giving me a bit of time today to do this. So just to show everyone this leaflet that we produced last year, we had a request from a Health and Social Care Partnership to provide a resource for community staff to raise awareness of the impact and the common symptoms of neurological conditions. And so we got together with our members. We're an intermediary with about 60 members, and got a small working group together to create this leaflet. So I'll just show you what it looks like here. It's very simple. We just have, it's aimed at, as I say, community staff, so people we wouldn't expect to have much of a knowledge about neurological conditions. And so it starts with a bit about what do you need to know, and then it has an avatar with some common symptoms, and we divide them into areas of the body or areas that are impacted. Making clear that this isn't something that, you know, you wouldn't be impacted by all of these, but someone with any neurological condition could be impacted by some of these. So it just shows the depth of impact of a neurological condition, which hopefully raises good awareness of the challenges of daily life for people. And then we had a discussion on how to provide top tips, and the group wanted to do like a post-it page just to make it like short and sweet. And so we had just some suggestions about how to, you know, to speak to people and how to relate to people, just with the aim of leading to better, more satisfying interactions between community staff and people with neurological conditions. And actually, it's nice to see the presentation before from Louise, because I think this ties in quite nicely with some of the priorities. And I picked up, I think, priority 17, which said, if it's about me, talk to me, consult me. And I think that came out very strongly in the work we did here as well. So we also wanted to make the point that carers and or family members require support as well, and just the headline being just be understanding and compassionate. There's a little bit about us at the bottom, and then you can actually click through this hyperlink and it takes you to a very short questionnaire. And we've added this in to measure impact, so we could also see where people were reading this from, what sort of areas they're reading it from, and how valuable they found it, and if they wanted more information. And I think we provide a contact to get in touch. So this is all I really wanted to show you. As you can see, we're going to be reviewing it next year in March. So if anyone has any suggestions for how to improve it or things that you'd like to see in the next iteration, then please do get in touch with me. I'm sure we can share my contact details after this.
Thank you, Alice. And so just this is aimed at healthcare professionals that maybe don't work regularly with people with neurological conditions, so it just gives them a better understanding of some of the challenges that people have.
Yes, but also social care staff, so it's aimed at a wider group, and it could also be used potentially in schools or in other environments as well. Okay,
and where can we find it?
It's on our website, but maybe it could be shared with papers that follow this presentation, this meeting today.
Yeah, we'll send a link round to everybody with the slides and the link to the recording. So that'd be great. Okay, I very briefly, I know that we've only got about 5 minutes left. I'm just going to share a wee bit of feedback on the previous session. Oh, thanks, Ewan. The last session was in March, and we did a quick user feedback survey. We had 10, I think it was about 28 people at that session. So we had 10 survey responses, 5 from the statutory and 5 from the third sector. And for those that weren't there, we focused that session on the development of collaborative governance structures. Again, a really pertinent topic, given that's really front and centre of the service renewal framework that's just come out. So slide 1, the session helped me to consider ways to improve governance structures for neurological care and support services. Only 2 respondents disagreed. There were also 3 neutral responses. Slide 2, please, Ewan. How likely are you to make changes to your governance structures as a result of attending the session? 3 were likely to do something, 3 were unsure, and 1 unlikely, with the remainder not relevant. Bear in mind, this is really aimed at the statutory sector and board-wide governance structures, so it wouldn't have been relevant for third sector. But comments cited complexity, lack of clarity around support from senior colleagues, difficulty in prioritising governance at a board level, and the breadth of the remit, limited ability of the third sector to influence change. All of those were cited as barriers. However, there were also respondents who felt that there might be action that could be taken forward as a result of the session. So on to slide 3. We did ask about topics to be considered for the next session, i.e. this session. So we had keeping people well in the community, innovative third sector services, and using the views of third sectors, of service users to shape the design of services and service improvement, which is the topic that we selected for this time around. In relation to we had other topics that were suggested, including purpose and objectives of the network. What can we realistically develop and implement with no resources or additional funding? Staffing levels for rehab services for neurological conditions, both in hospital and in the community, and work in partnership with local authorities. So just in relation to the purpose and objectives of the network, we can only really run this as a community of practice at the moment. So it's information sharing very much along the lines of what we've done today. There might be more that we can do if resources become available. The progress updates submitted by NHS boards recently have been really giving us a much better understanding of how plans are developing, and we'll analyse those in the coming weeks. That'll provide a better understanding of the themes that we should be focusing on through the network. And the individual meetings with boards are also proving to be really helpful in shaping the direction of travel. So in relation to workforce, there are a number of work streams that are nearing completion that will support organisations in relation to workforce development and planning. So we do intend to run a focus session around that later in this financial year. So we have a number of topics that we could cover for the next session. And again, we've put a poll up, so I'll just talk you through the rationale for those a little bit. So improving mental health support for people with neurological conditions. This was a massive theme coming out of the patient experience survey led by the Neurological Alliance of Scotland. Care opinion, patient experience survey tool. So this is a new survey tool that will provide real-time patient experience data, and it's projected to be launched later this year. So it's a partnership between Scottish Government and Care Opinion, and it'll provide a snapshot of measurable progress over time. So we could invite colleagues along to hear about that. The National Patient Experience Survey results. NEOS recently ran a series of sessions to hear about that survey, but we could, again, there's another opportunity potentially to hear about that. Scottish Epilepsy Register provides much improved patient care for people with epilepsy, linking to existing data systems. So it's working really well in NHS Greater Glasgow and Clyde. It got a Chief Executives Awards within that board, and we're aiming to roll this out across all boards, so it might be useful to showcase this. Sharing practice and improvement plans has been asked for before, and we'll be developing a themed overview from the progress reports that have come out. But if you'd like to hear more about what different people do, then please vote for that. And then keeping people well in the community, innovative third sector services. That polled well the last time, and be helpful if you could give us views on that. I think that might need a kind of standalone, maybe in-person, more in-depth session to do justice to those projects, but it's still something we'd like to think about. And then finally, waiting times. So data shows there's considerable variation in waiting times across the boards. So it might be an opportunity to share practice from where the waiting times are shorter. And then finally, other. If you do want to vote for that, please put it in the chat, because we don't have a free text box. So please vote, and we will take that data back. I'm afraid we don't have. We haven't figured out how to share the live data. But we are going to, it is 1 o'clock. I know some of you will want to either move on and get your, oh, thank you, Ewan, instant results. So yeah, we've got the CFSD have got a session at 1, so some of you will be moving on to that or to other things. So thank you again. Please do take the time to feedback informally if you have other comments or other topics that you would like to discuss through the network, and enjoy the rest of your day. And thank you so much, particularly to our presenters, for really fascinating inputs, and thank you all for coming along.
Thanks, Richard.
Bye.